Hey there, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you are here with me. And if this is the first time you're listening, well, thank you for making Let's Talk Micro one of your podcasts. Okay, so I'll be brief and then we'll jump into the episode. Well, if you work in a lab, you're familiar with Brucella, and this episode is about the latest updates to the guidelines regarding Brucella. One of them being Brucella being removed as a select agent. So in the episode, we go over the latest updates. We give an overview of Brucella. We talk about taxonomy and nomenclature. As we always like to do, Let's Talk Micro, we break it down. And in the episode, I am joined by doctors Laura Filkins and Paige Larkin. So let's go ahead and listen to it. Brucella. Those of you that work in the lab, you definitely know it. You know that maybe you're doing that proficiency survey and you have your chart and you're working things out, or maybe you have been one of those unfortunate ones that you have these plates around and everyone is looking, oh, I can't identify this, it's not growing well, what is it? And then a few days after, boom, turns out there was Brucella and people were exposed to it. So today, I want to talk about recently the American Society for Microbiology. They published some updated guidelines for Brucella. So with me, I have two guests today to talk about those. I have Dr. Laura Filkins and Dr. Paige Larkin. Everyone, welcome to Let's Talk Micro.
Thank you. Thank you. It's great to be here.
My pleasure. Thank you for being here. So I think let's just start kicking things off with a little introduction. The audience knows your name, so maybe a little bit about what you do and your background in microbiology.
Sure. I can start. So I'm Laura Filkins, and I am currently a microbiology laboratory director at Children's Health in Dallas, Texas. I'm also an associate professor in pathology at the University of Texas Southwestern Medical Center. And I oversee and help direct both the classic microbiology and the molecular microbiology sections of our laboratory for our system.
And I'm Paige. I am the Program Officer of Clinical Microbiology and Public Health at ASM. I was previously a laboratory director of a molecular microbiology laboratory and have since moved into this nonprofit space. As part of my job, I work with Laboratory Practices Subcommittee, which Laura's on. I oversee them as their staff member, and I also work in coding reimbursement.
Well, welcome again. Happy to have you here. So let's start with, with as I mentioned on the opening intro, there were some updates to the Brucella guidelines. So what prompted these and what are some of the most significant changes?
So our ASM Lab Practices Subcommittee, we review all the Sentinel guidelines to ensure up-to-date, accurate information. And there have been a lot of changes with Brucella, which prompt us to start with that one. And one of these changes is the recent nomenclature and also the downregulation of the select agent status. So recently, Brucella was grouped together with classic Brucella was grouped together with Ochrebactrum. And with that led to some confusion as Brucella was expanded then. So now the previous select agents Brucella species are referred to as brucellosis causing Brucella species, or BBS. And those that were not previously part of the select agent group are now just Brucella. There's also updating the case definition of what brucellosis was in 2025. And we also wanted to recognize that there have been many cases now of gram variable staining of Brucella, which has led to misidentification of this organism and laboratory exposures. We also updated specific specifications like specimen collection and added about the discontinuation of the isolator lysocentrifugation system. We also wanted to really highlight in any of our guidelines that when you're working with select agents or highly pathogenic agents such as this, we want to make sure that there's an emphasis on performing presumptive or not performing presumptive identification and instead ruling out these organisms rather than trying to identify. The biggest change is that Brucella was removed as a select agent, or these BBSs were removed as a select agent. This does not mean that any biosafety protocols have changed. It's still highly infectious, and you still need to rule out. There's little changes down the road of like transportation, documentation, destruction.
Yeah, and I like how you mentioned, emphasizing and to make sure that they don't try to presumptively identify it. And, because this is one thing when I mentioned when you have even though, right, we treat our we get our surveys and you treat them like patients, but when you get that famous like LPX, right, you kind of just already thinking in the back of your head, okay, let me get my bearings, let me read, let me start getting these things in order, and then you sit down and you start checking, okay, I have my catalase, I have my oxidase, and positive, negative, what next, and so I like how you say that, and I'll ask you in a little bit about the taxonomy because, as you said, it can be confusing sometimes seeing some names on your screen, right, when you're doing Molotov and things like that. So, but let's just start with a brief overview of maybe you can explain to the audience, what Brucella is and why it's so clinically important.
Yeah, absolutely. So Brucella is a genus of gram-negative bacteria. They're usually coccobacilli. And as Paige mentioned, there are species in this genus that are clinically associated with the disease brucellosis, but not all cause brucellosis. And so the species that do cause human brucellosis are Brucella melitensis, suis, abortus, and sometimes canis. There are also case reports of others, but those are really the four main ones that we see. The brucellosis causing species of Brucella, they're zoonotic, so they actually live in other organisms like cattle and pigs, goats, sheep, dogs, and it depends on which species. They have different hosts. So the risk factors for humans to acquire Brucella is usually direct contact with those infected animals. And it can either be working with the animals, or also we see cases because of consumption of animal products, usually unpasteurized milk and or milk products, and it would have come from an infected animal.
Okay, and let's go ahead and let's touch a little bit on the taxonomic updates, and that's something, right? It causes all sorts of controversies in our community. And one thing is now, as you mentioned, Ochrobacterium, and then you're doing your moldy, this, you have this, and then all of a sudden you see Brucella. Bottom line, a lot of times, these changes are not well received. It causes a lot of controversy. So let's touch about that. Maybe we can start with talking about taxonomy versus nomenclature. Who decides? Let's start with that.
For sure, and I appreciate your using the word controversial. I would certainly agree with that when it comes to Brucella. And also the issue is that taxonomy and nomenclature, it is quite complicated and it is very confusing. So I'll kind of back up a little bit. The organisms that cause brucellosis, they've actually gone through many different names, not just recently. And the first recognized name was Micrococcus melitensis. The genus name Brucella actually wasn't applied until the 1920s. But then fast forward, we've been, applying the name Brucella pretty routinely for what's that, almost over 100 years. But more recently, the composition of the genus Brucella is what has really become the topic of controversy. And so specifically, it's been proposed that the organisms of the genus Ochrobacterium might actually be so closely genetically related to Brucella that they could merit being one genus. However, that is not uniformly agreed upon, hence the controversy. So, part of the reason that there is controversy is because there is no one single standardized, uniformly accepted approach to performing taxonomic studies. Rather, it's an evolving field, and there are a lot of different approaches and a lot of different taxonomic beliefs. So, taxonomy is really how we arrange the tree of life and what the genetic relatedness of organisms is. But then we also have this concept of nomenclature. And so, nomenclature is really talking about the names that we apply to organisms. And of course, we use names to communicate about those organisms. We use names to communicate about taxonomy. So, when there are taxonomic updates proposed, if the authors of that study or other authors decide to go through a formal process called validation, getting the nomenclature validated, then usually or often in association with taxonomic updates comes a nomenclature update as well. And there will be additional validly published, validly accepted names. The key thing with the validation of nomenclature or names, though, is that just because you have a more recent name that is validly published, it does not automatically supplant any of the earlier validated names. And so, what that means for us today in 2025, or really for the past few years, is that it's acceptable, for example, to use the name Ochrobac- Ochrobac anthropi or Brucella anthrope for the same name. Both are acceptable. Both are validly published. But of course, that creates challenges for labs and clinically because there's a really strong word association between the genus name Brucella and the clinical disease brucellosis. And yes, it is true that even before moving Ochobacterums around, there were Brucella species that didn't cause brucellosis, or we didn't commonly see them causing brucellosis in humans. But to be fair, we rarely would encounter those Brucella species in the laboratory. Whereas with Ochobactrum, we actually do encounter those organisms in the laboratory, and so it's creating more confusion about whether or not the organism actually what it means significantly for the patient when you see that term Brucella. So I think for the laboratories, it's really important to think about how we're communicating about these organisms, what we call them, how we provide that information to our providers, and what the safest and best approach is. And there's not one right answer here. I think a couple of options are to either continue to distinguish the organisms by using Ochobactrum and Brucella, so continuing to use Ochobactrum for those organisms and then Brucella for the other organisms. Or another way, which Dr. Larkin mentioned, is that you could move towards using the term brucellosis causing versus non-brucellosis causing Brucella species.
Yeah, and when it comes to like the nomenclature, I know from other conversations that I had, one thing that they recommend is using consistency in your lab, with those, and when it comes to the organisms, like even with your LIS, like if you report it, you have like a name and parentheses, maybe what it used to be known, that way not to cause confusion. And for Ochrobacterium, yeah, it's I'm not gonna name specific instruments, but before the Molotov days, we had some instruments that to identify it, and we used to see it. We do see it. So thank you for mentioning that. Okay, so one of the things that was mentioned was that one of the changes was the removal of Brucella as a select agent, and the Let's Talk Micro audience is very varied. We have students, we have professionals, all sorts of occupations in the field. So maybe let's start with some basics here, and maybe can you talk about what a select agent is?
Of course. So, what's important to know is that a select agent is determined by either the Health and Human Services (HHS) and CDC, or actually by agriculture, so USDA or APHIS. And what these are is a select group of biological agents that have been determined to have the potential to pose a severe threat to public health and safety, to animal health or plant health, or to animal and plant products. And so it's not just human diseases, it's not just animal, it's a combination. And so you can actually be categorize this list into what's considered human and public health, which would be HHS and CDC, or agriculture. Brucella is one of those agents that actually overlapped and was found in both categories. And it was actually removed from both. But what's interesting is that every or biannually, HHS is required to review select agents in considering these criteria, such as the effect of human health exposure to an agent or toxin, the degree of contagiousness, the availability and effectiveness of treatment if someone were to be infected, and also vulnerable patient populations and how that would impact them. But when HHS determines that potentially an agent could be removed during these reviews, which is what happened to Brucella, they actually solicit public comment and feedback. So they ask the public, especially scientists and researchers, to provide support or support against or for the removal of these organisms. And that's what happened with Brucella. They want to remove organisms when they can because it can actually allow for more robust studies for wildlife prevention and treatment. And often, if these agents aren't considered to be actually used for BT or unlikely to be used for bioterrorism, why include them on this list? Because it's extremely restrictive. It limits research studies, and burden for even developing treatment. So when that happens, it's removed from a list. The biosafety requirements do not change. It's still very infectious. It's just additionally those criteria such as like shipping and documentation, those do change and lessen.
So that's something that I was gonna ask. So this change, and maybe you can just touch a little bit for the audience again. I know you just talked about it, but so this change, for the lab, what does it
For the
mean?
lab in particular, it's still highly infectious and remains a reportable disease. If there are potential isolates, the lab should not attempt to identify at this time. They should send to their national reference laboratory or the response laboratory network and have them actually identify. So the process is still to rule out and refer because, again, it's still very infectious.
Okay, all right. So, we talked about instead of not doing presumptive identification, just rule it out. Why has that focus shifted from presumptive ID to rule out procedures at the sentinel lab level?
We should have always been ruling out at the central lab level and not identifying. And so this is just a clarification with this update and emphasize to do that approach. Um, I would say public health laboratories have the ability and training to identify these agents, and they're extremely useful in actually doing that. So to keep our laboratories safe, we should really just focus on ruling out and referring. We have, as you said, there have been misidentifications with moldy toffs and other just biochemicals in general. So keeping the laboratory safe is of utmost importance.
Yeah, I don't like it because the one thing that as I find myself as many years pass and the years go by and I have some experience teaching and you have to be specific. So even though something is kind of already known and it's good to say it specifically, so when someone says, "Well, show me the document, show me this," it's like, okay, it says here this, and we have to be specific. Okay, right. So we're laboratorians and we like knowing about the organism. So what are some of the key clinical features of brucellosis that laboratorians and clinicians should be aware of today?
Sure, I can talk a little bit about this. So when we're thinking about clinical features, to be honest, for the most part, this is going to be our patient-facing colleagues that are really assessing these. But I do think it is helpful for laboratorians to know as well. And so, just kind of very briefly, brucellosis, so that's the infection that or the disease that is caused by of course, brucellosis causing Brucella species, as we just discussed how to terminology those. And it's usually an acute febrile illness, although it can also present quite chronically. Symptom onset can either be relatively rapid or somewhat slow, so ranging from days to weeks typically. And then some of the common symptoms are fever, fatigue, and joint pains. But also commonly reported are muscle pain, back pain, sweating and chills, decreased appetite, and several other symptoms as well. So they can be rather broad symptoms. Brucellosis can affect many different organs in the body, and it can also be associated with a variety of complications. But particularly notable is spinal infections, actually. So again, when assessing the risk factors, it's really important for our clinical colleagues and our infectious disease physicians or places where they don't have infectious disease physicians that would maybe be consulted, anyone really who is helping to diagnose a patient to think about those risk factors. And we talked about earlier contact with potentially infected animals or consumption of unpasteurized milk products. So on the laboratory side, we're relying on the expertise of our colleagues to give us a heads up, but we know that sometimes it isn't considered until later in the process. And so to help keep ourselves safe, we just additionally, as part of our routine practice, I'm sure all of the audience is very familiar with these processes, but we're keeping in the back of our mind every time we look at any culture, some screening phenotypes for not just Brucella, but Neisseria meningitidis and other select agents. And so thinking about growth rates, what does a gram stain look like, and then going into your rule out process, although we'll talk about some caveats with those processes as well.
Yeah, and even when the patient has been seen, maybe that's not being suspected, and you do have unfortunate situations that I have been through where we're not exposed, but where it turns out that then after subsequent conversations, it was suspected and nothing was said because you go to the history, you're trying to see, and there's no and especially if your lab functions as a reference lab, you do have in the back of your mind when they send you like a gram-negative coccobacilli for identification. That's just the bells are going there. Be careful. Start checking things and proceed with caution. Okay. There's also something on the guidelines that I was reading, and for the audience, and maybe we can clarify a little bit. What is the CSTE definition of brucellosis?
Yeah, sure. So CSTE, it stands for the Council of State and Territorial Epidemiologists. And the CSTE, they have several case definitions. One of them is for brucellosis. And most recently, they updated and released a case definition this year in 2025. So it's actually really intended to be used for public health surveillance purposes. And it's a way of applying a uniform approach to categorizing human cases of Brucella or brucellosis. So if we compare the more recent release in 2025 to the prior one, the prior case definition, which was released in 2010, the 2025 definition has a couple of modified clinical and laboratory criteria for classifying cases. And for example, they included now a classification of a case as being suspect and what the definition of that would be, in addition to the existing classifications for probable and confirmed. And in general, whether it's a suspect versus a probable or confirmed case, these are determined based on if the case meets specific laboratory and clinical or epidemiologic criteria. So, if anyone's interested in taking a deeper dive into that, you can go onto the CDC's website and look for the National Notifiable Diseases Surveillance System for brucellosis, and they have the CSTE definitions there, or you can just find your favorite search engine and write in there CSTE committee documents and maybe add Brucella as well. And it should pop up close to the top of a search engine.
Sounds good. And for the audience, I will look it up, and if I find a good link, I will put it on the show notes. I know you like having things accessible there, so I will look, and if it's there, don't hold me to it, but I will put something in there. Okay. One of the things, in the lab, when we're working with organisms, and there's already some safety measures that we need to take. When it comes to suspecting Brucella, maybe you can talk more about safety measures that the lab should be when you're handling this.
Yeah. So, in terms of safety measures, we still want to treat it exactly as we did before it was downregulated. If Brucella is suspected, immediately notifying your public health laboratory, your designated one, which may be a county, it may be a state, depending on where you are. And then the laboratory response network will provide the referring lab with additional guidance and recommendations for obtaining the specimen or isolate and submission for confirmatory testing. With that being said, we should not be shipping specimens without permission from your reference laboratory without prior arrangements. And at the same time, if you suspect BBS and you cannot rule it out, notifying the ordering physician is really important as well. And then if the patient is hospitalized, notifying the infection preventionist and or infectious disease service so the patient can be treated appropriately, infection prevention can be taken, and further investigation into the patient's history can be made. And then in terms of confirming laboratory exposure, making sure that all plates are taped up the minute that BBS cannot be ruled out or it's suspected. But for those who are exposed, they should be following up with the infection control employee health to ensure their risk of exposure. So there's differences in terms of how far away you are, when a plate's open, are you actually aerosolizing, etc. So that's really something to check with your local institution on follow-up and whether or not additional testing or prophylaxis is necessary. Destroying the organism following any of your laboratory protocols that state for any highly pathogenic organism how you destroy it, whether it's with bleach or another method, that should be followed for these. And so just keeping track of those plates, taping them up, minimizing exposure risk, not aerosolizing them, not putting them on moldy top. Those are really key. Working with everything inside of a biosafety cabinet with gloves and proper equipment, that is important for reducing exposure.
One of the things, as you mentioned, you have your guidelines, especially when you're doing your testing, and you have the steps that you follow. Let's say you're doing like your catalase, your oxidase that I mentioned. One of the things with the gram stain is that the Brucella can stain gram variable. So maybe we can talk a little bit about that, and how does that impact that identification and safety in the lab.
This is a very tricky feature about Brucella, and I think actually a quite dangerous one. Yes, so it's very important. It has been increasingly reported from sentinel labs and also in the literature, this feature that while biologically Brucella has a gram-negative structure, and in theory it should gram stain gram-negative, so pink. Unfortunately, sometimes the organisms are either gram variable, or some labs have even reported quite uniform, very gram positive staining. And this seems to be particularly true from positive blood cultures, but could happen from any specimen type. Additionally, so not only is it gram variable sometimes, but other things that make it kind of tricky is that we usually think classically of Brucella as being coccobacilli, but some labs have actually reported examples of the brucellosis causing Brucella as being quite elongated to the point where they appear like they're rods. And then additionally, some labs have reported Brucella growing on colistin and nalidixic acid agar, and usually we use that for our gram-positive selective media, right? And so there's all these different features that are really working against us when we're trying to use our classic features to do that quick screening. And it's a challenge because we do need to balance keeping our staff safe and knowing what to look for, but also being realistic about our workflow. Of course, we can't sit there and rule out every single thing that comes through the lab. And so when thinking about that, there might be a few additional clues that we can use to really pick up on a potential atypical brucella. So, one of those is, especially from blood culture bottles, the growth rate to positivity. And it's been reported that most brucella, or at least brucellosis causing brucella, take at least 3 days to flag positive in your standard automated blood culture system. And that's a little bit on the longer side. So, most organisms, while yes, we routinely hold the bottles for 5 days, most organisms will flag positive or cause the instrument to flag positive in less than 3 days. So that could be something that if it's a little bit on the longer side, maybe pay extra attention to it. We can also look for the growth rate on our subcultures, which is part of the routine rule out process. I do want to put a caveat here, though, too, because we've started to hear from colleagues who are using TLA, or total lab automation, that when you incubate these organisms in a continuous incubation system where the doors aren't being opened all the time, the growth rate may actually be a little bit speedier than we have historically thought of it. So that's another thing to look out for. And then again, we're going to look for clues of an organism not growing on CNA or McConkey, with the caveats that I already mentioned, in combination with the gram stain and the morphology. So just putting all of the pieces together and recognizing that many of them could be atypical. Hopefully we're not going to have an isolate where all of the things are atypical, or else that's just evil.
Yeah. And of course, acknowledging the seriousness of Brucella and other organisms, right? But as the science of it, and as I like to, because there's no other word for it, right? The nerdiness of it. It's just, right? That's why I love this field so much. Like, it keeps us, we're always learning. We think we know something, and then next thing you know, something else changes. You see something on a media that maybe shouldn't be growing there, or you see a different morphology. So we constantly have to, right, to evolve and continue learning. So one thing, with Molotov, and we talk a little bit about Molotov, and people love the Molotov getting that magic answer, right? You don't have to wait till the next day. You put it there, and all of a sudden, you get that answer. Why are automatic systems like Molotov not recommended for suspected Brucella?
Yeah, Molotov is not recommended for a couple of reasons. One, there is a potential of aerosolization when loading that Molotov disk in, which would then pose a risk for biosafety. And I had this previously as well. I've seen this as a laboratory director. If something gets put on the moldy, then anyone in that vicinity, and that's usually a lot of people, will then be considered potentially exposed. So that's a risk. But importantly, some of the databases may be inaccurate. So it may not be called Brucella. And with the recent new classification of Ochrebactrum into the Brucella genus, laboratories do need to be aware that they may get something that is a non-brucellosis causing Brucella being flagged as Brucella that may be Ochrebactrum. And so we recognize that isolates may end up on the moldy. They should never be ended up intentionally, but just to keep in mind that the misidentification can happen. And then also keep in mind that snake is flagged Brucella, it may be an Ochrebactrum. And so just knowing that there's kind of a gap on accurate diagnostics using Molotov, in addition to a potential safety concern, that's why it's not recommended.
Yeah, and one thing also beyond Brucella too, that I always like to tell people with the moldy. Yeah, you do get that answer too when it comes to other organisms, but you need to correlate it with what you have and your test, just because don't take, Moldy's word for it. And we still need to be able to, put all those things together, your morphology, your biochemicals, and create that knowledge base in your, then from there, just not accept that result. And before I jump to my other question, one thing that you say, Dr. Filkins, was with systems that are closed, we definitely have been seeing, right, that increase, well, decreased time for that the organism is positive. Very true with blood cultures. I remember we used to have like a blood culture system that you had to open the drawer, scan your bottles, and then we switched to another one where you just load the bottle and it's closed. And you started seeing all these things like, like faster, and even after a few hours, maybe even you don't see anything initial, you do like a cytospin and then you see the organisms. So very true. Okay, so as someone involved in microbiology, what message do you have for labs navigating these changes?
I think one important message, which we've just actually touched upon too, is that a single biochem or single growth rate should not be used to rule out an organism. Especially when we look at TLA, something grows faster than it's intended, but everything else matches. Rule that out. Send it out. Talk to your appropriate public health laboratory. And that happens with anything, whether it's catalase or oxidase or any select agent. If one thing is off but the rest matches, really consider that carefully. And we're updating all of our Sentinel guidelines to reflect this because it's not just Brucella, it's any select agent. For instance, there's known issues like with catalase, if it's left out too long, that can give wonky results regardless of the organism. And so we're trying to include those caveats and figure out the best approach for sharing the information in the community by updating these guidelines. And also that even though Brucella has been downregulated as a select agent, the biggest takeaway is its infectiousness did not change. Brucella did not receive the call and say, hey, now I'm no longer that infectious. I'm not a big deal. Everything remains the same there. Tape up your plates. I keep harping on this, but treat it as if it's a select agent. You just don't have to do everything downstream that you have had to before.
They don't listen to anything that we say, right? So, but very important
And
to make
that's a
that
common misconception I'm hearing in the community too. Well, if it's not a select agent, can we just throw it on the moldy? Can we just resume with our lives and keep testing? And the answer is no. This is really just a regulatory standpoint, not an organism. Nothing has changed with the actual organism itself.
Thank you for emphasizing that. And speaking of updates, is there any other organisms or any other updates coming down the line?
Yes, they're actually updating all of the Sentinel guidelines. At this time, we have updated the smallpox guideline, anthrax, and Brucella. The rest are being edited and currently under review. So we made great progress and we should see them in the coming months to year. The process does take a lot of time, and we are officially collaborating with the CDC. They have a whole division dedicated to these different select agents. And so having their expertise has been really useful. We are also checking the CSTE guidelines to see how those changed because most of those have been updated since the last publication date over 10 years ago. And really, we're coordinating with APHL. I want to acknowledge them, the Association for Public Health Laboratories. They are amazing, and they have been a huge source of the public health information. So the ones who are actually identifying these organisms are the ones who are helping us with these guidelines. So I do want to give them a huge shout out.
Okay, and and when it comes to resources and you know we have guidelines in like in the clinical microbiology procedures handbook and what other bioterror agent resources exist for laboratories out there so you can tell the listeners.
So APHL and ASM have worked together on the recognized rule out refer biothreat agent bench cards. So once these Sentinel guidelines are updated, we will go through and update those bench cards as well as the posters. Also, a great resource is a CDC website for up-to-date information as well. And so we are continually reviewing and updating. It does take time. And I also really want to recognize Dr. Filkins and Dr. Shea, Rosemary Shea. They're the head of our lab practices subcommittee here at ASM, and they have been phenomenal. And this has been a huge endeavor. I've been here almost 3 years now, and we have really worked through these guidelines. So I want to give a huge shout out to the entire LPS team and our leadership on those teams.
I appreciate that, and we do appreciate all of our collaborations as well. And Dr. Larkin, of course, just emphasizes, but I want to extra emphasize the bench cards because when thinking about our lab staff and how we actually practically use these rule outs, I know these documents they're full of really great information, but they're they're deep and they're many pages. And if you are on the spot with an organism that you're trying to determine what to do next, while the Sentinel guidelines are excellent, the bench cards are maybe a little bit more user friendly in the moment. And one of the things that actually the bench cards also include, because our Sentinel guidelines currently are structured as Brucella and anthrax separately and Yersinia pestis separately and each one individually. But the work card or the bench card, sorry, at the beginning of that document, and it's kind of like flippable, heavy plastic cards is what we're referring to. But at the beginning of that document, there's a nice flow chart that basically starts with the culture and you think about your growth rate and then it tells you, okay, you have ruled out this organism based on these results, you haven't ruled out this organism, and so it kind of compiles all of those things together. So even today I would still say, use those bench cards, and then again we will be updating them to make sure that they correlate closely with the Sentinel guidelines in the coming months, and so then we can switch over to the newer version of the bench cards as well.
Oh, I think an important note, though, on this in general is anytime you have printed materials, it's really important to check the date on those. I know often labs will print, these guidelines or have them referenced at their desk, but as we update, it's important to switch out with the updated version. Always kind of keep a record of that.
Okay, well, thank you for that. So before I ask a question that I like to ask the guests, and I get all sorts of interesting responses. When it comes to this, the updated guidelines with Brucella and overall, is there anything else that you want to add?
Stay safe and stay vigilant.
Well said. Okay. So, I like this question, as I said, I like seeing what the responses are. And, right, we all tend to have this favorite bug that we like it for any amount of reasons. Either it has that significance, maybe we worked with it in school, we did some sort of, graduate studies and on it. Maybe we just like the way it looks or any reason, maybe some sort of mechanism. So we don't have that favorite bug. So I think I'll start with you first, Dr. Filkins, and then I'll move on to Dr. Larkin. So, Dr. Filkins, what is your favorite bug?
So mine's a little bit of a weird one, actually. I guess that's what you're looking for, though. So I love the organism Dilosogranulum pigrum. It's a gram-positive cocci. It's a bacterium. And in the clinical laboratory, at least in my laboratory, where we encounter it the most is when we're screening cystic fibrosis cultures for Staph aureus. So it's because this organism, Dilosogranulum pigrum, it also grows on mannitol salt. And so anything that grows on mannitol salt from a CF culture, we screen. And then we find out from the lovely Maldi that it's Dilosogranulum pigrum. But that's not actually why I love it so much. I think it's a really cool organism because it's usually normal flora, and it's probably at least beneficial, if not even protective flora. So there have been some really nice studies published, both looking at kind of patient comparison as well as in vitro studies. And they've shown that Dilosogranulum pigrum and Staph aureus have inverse relationships. So from a colonization standpoint and also in vitro, Dilosogranulum can inhibit the growth of Staph aureus. And then additionally, when thinking about pediatric patients, there's an inverse correlation between Dilosogranulum and Streptococcus pneumoniae, and also an inverse correlation with resulting otitis media. So it's a pretty cool bug. I feel like it's underappreciated.
Wow, that's a great answer. And yeah, I do enjoy hearing about unexpected ones or unusual. I mean, I have had some sort of great answer. Even like commonly seen organisms in the lab. I had one that I did about strep pyogenes, and the reason was great. But wow, I love that one. All right, so Dr. Larkin, what is your favorite bug?
Okay, mine is not as cool or detailed as Dr. Filkins, but mine's actually a virus. I love viruses, but my favorite is rabies because I just find it such an interesting virus. During my fellowship at UCLA, my CPAP fellowship, we were able to rotate through LA County Public Health, which is this phenomenal public health team. And you actually get to see how they process for rabies when it comes to bats being submitted through LA County. And I just think that it's such an interesting virus because it lays dormant for a while, right? And the way that it progresses, it's extremely scary. But we have such great vaccines and immunoglobulin to really help with preventing, and we have great prophylaxis. And I just think it's an interesting virus that really shows the intersection of like the One Health between animals and humans. And it's one of those things that we've had amazing infection control measures done. So I think it was Rodney Road at ASM Microbe this year did this whole presentation on rabies and the history. And it was my absolute favorite talk of all of Microbe. And they talked about how they actually used bait that had vaccine in it and put it on the border of Texas. And so animals would eat the bait thinking it was just food. And it actually prevented canine rabies and other rabies from crossing. And so it actually really helped in that control. And they had to like drop it from helicopters and planes to get this food into the wild. Did not hurt the animals anyway. It just prevented them from getting rabies. And I just thought that was so cool. And that's why I geek out over rabies, but not as cool of an explanation as Laura's. But I just think it's a really cool symbiosis with public health, clinical labs, animal welfare and care. Like it's just this great relationship to prevent it. Rabies itself is not a great relationship, but the prevention measures is just like a huge feat for public health.
Good answer too, and of course, you mentioned rabies, and I thought of Dr. Rody. Shout out to him. Always great friend of the podcast and has been here multiple times. And we did an episode which actually World Rabies is this month, so World Rabies Day. So, anyways, this has been so great. Thank you so much for taking the time to be in Let's Talk Micro, and hopefully when more updates come out there, you can come back and we can talk more about them. So, Dr. Filkins, Dr. Larkin, thank you so much for being in Let's Talk Micro.
Thank you for inviting us.
Yes, thank you so much.
My pleasure. Well, there you have it. I hope you enjoyed this episode with the latest updates regarding the Brucella guidelines. And of course, stay tuned as more guidelines get updated. I will make episodes about it so you can be informed. Well, micro friends, as always, you can find Let's Talk Micro on any podcast platform like Apple, Spotify, Amazon Music, GoodPods. So I invite you to subscribe, download episodes, and if the app allows you to do so, please go ahead and leave a review. As for our socials, you can find us on TikTok, Instagram, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, LinkedIn as Luis Plaza. There's the website, letstalkmicro.com. And if you have any feedback, any episode suggestions, you can submit those via the website or via an email, which is letstalkmicro@outlook.com. If you want to support us in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. And one thing I have been saying on the past few episodes is that we are approaching a download milestone. So maybe now's the time that I invite you to go ahead and go back, see if you missed any episodes, and download those. As always, I am so grateful for the support. And if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. As always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, it's the end of this episode. I hope you enjoy learning about the latest updates regarding Brucella. As always, I enjoy sharing this information with you. Stay tuned, great things coming your way. And as I said, we're about to approach a download milestone. So please go back to the catalog, see what you missed, and download those. Thank you so much. So please continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.